Hello, everyone, and welcome to Fracture Prevention Central, implementation of a secondary fracture prevention program. Where to start depends on where you sit. Sponsored by the National Bone Health Alliance. You may submit your questions throughout the conference via the chat pod, located in the lower left-hand corner of your screen. Simply type your questions in the available box and click the Send Message button. Questions will be answered at the end of the presentation. I will now turn things over to David B. Lee, MPA, Executive Director of the National Bone Health Alliance, to introduce today's speaker.
Thanks so much. I really appreciate everyone's time today to be on the second in the series of 6 webinars we'll be sponsoring throughout the end of 2013 related to Fracture Prevention Central and the Fracture Liaison Service model of care. Before we get started, I just wanted to make sure that just to kind of level set folks so that they understand at a high level what a Fracture Liaison Service model of care is. So it's a coordinated preventive care model which operates under the supervision of bone health specialists and collaborates with the patient's PCPs. Really make sure that post-fracture care is coordinated through a Fracture Liaison Service coordinator, a nurse, NP, PA, who ensures that patients that fracture receive appropriate diagnosis, treatment, and support. We track those patients with recent fractures through a population registry, and there's a pretty established process and timeline for patient assessment and follow-up. This program has been running over the last 15 or more years, both here in the United States through the American Orthopedic Association owned the Bone Program, Geisinger Health System, and Kaiser Permanente, internationally in the UK, Canada, Australia, and many other countries. All these programs have really shown that you can greatly reduce the number of recurrent fractures as well as also provide cost savings and improving patient outcomes. So a model of care that really the goal of the NBHA is to foster as many folks as possible in the open and closed systems running FLS programs, and really the whole reason we're here today. So just want to highlight at a high level Fracture Prevention Central, which is an online resource that NBHA launched in the middle of March 2013 that I hope all of you have been able to access. Really, we launched it after hearing feedback from folks that they now knew what an FLS was, but they really were challenged to figure out how to get started. So what we did is we worked with all the major programs who shared their tools that they've created, and really we laid out the whole process, how to sell it to your administration, et cetera, all on fracturepreventioncentral.org. So instead of kind of everyone reinventing the wheel, really the goal here is to facilitate the use of existing knowledge and use those tools in each person's individual setting. And that's not only best practices, experiences, and tools, and one of the things that we'd like some feedback on, and that will be part of the evaluation on the tail end after the conclusion of the webinar, is ideas for other tools and other ways that we can make this a more virtual community. So we'd love to get feedback from you all on that. So we have over 700 folks that have registered to access the free Fracture Prevention Central tools to date. So really pleased with the level of interest in just a few short months in being able to access these tools and to really get started in setting up FLS programs, or for folks that already have them running, improving them. So here's my contact information. Certainly don't hesitate to contact me via email, over the phone. We can also, as we have bandwidth, have individual calls with folks to talk about their specific situation, to pull in some other experts like Rick Dell from Kaiser that was on the last call. So really pleased to be able to support you in any way that we can to move your individual program forward. So with that, just wanted to now introduce Dr. Oates, who is the faculty on today's webinar. So Mary Kay Oates is the founder and medical director of the Marion Osteoporosis Center at Marion Medical Center in Santa Maria, California. She has been specializing in the diagnosis and treatment of osteoporosis since 1997 and is a certified clinical densitometrist. Her thriving private practice on the Central Coast of California also focuses on the evaluation of nerve and muscle disorders with EMG and nerve conduction studies. She is also actively involved with community education and outreach projects aimed at the prevention and treatment of osteoporosis. She founded the Marion Osteoporosis Center and later expanded the concept to the Dignity Osteoporosis Quality Initiative. She is active with consulting, research, and teaching for ISCD on the use of DEXA for body composition. Dr. Oates is a graduate of Ohio State University College of Medicine and the University of California Irvine Residency Program in Physical Medicine and Rehabilitation. She is board certified from both the American Board of Physical Medicine and Rehab and the American Board of Electrodiagnostic Medicine. With that, I am pleased to introduce to the group Dr. Oates. Thanks so much.
Thank you, David, and thank you, Sherry. I'm really excited to be here today to share with you a little bit about our experience in setting up an osteoporosis fracture follow-up program. And I want to start off by saying that this is definitely a process and evolution, and that today's webinar is really just to get you oriented in the possibilities that you have to conceptualize and really make the first steps in moving forward. So a little bit about me. I am the medical director for the Marion Osteoporosis Center, and that was started in 2008, and it was made possible by a private grant from a patient of mine who wanted all patients to have a good experience and proper background when they were making decisions about their diagnosis of osteoporosis. And so we were very lucky that we had this funding, and we were able to start a program which was heavy and pretty much solely included education for both the patients and for the providers in our community. And so we initiated a physical therapy program, fall prevention programs, dietary counseling. We worked with the city on senior fitness services. And all of this was really made possible by our already collaborative outpatient chronic disease program. We already had a congestive heart failure program, and we already had a diabetic education program. So our administration was very receptive to this. So what we started doing was identifying patients with fractures over age 50 that were seen at any of our hospital locations. And it was a very basic start with giving them discharge instruction sheets that indicated that they may have underlying osteoporosis and would be at risk for future fractures, and that they should talk with their primary doctors. We expanded that to include English and Spanish, and then basic handouts that were already available so that we weren't reinventing the wheel. We also started using our hospital quality improvement staff and hospital volunteers to contact the patients personally and ask them questions and really nudge them into getting more follow-up. We gave them information about an osteoporosis library that we had set up. We have slides there. We have resources in multiple language. And unfortunately, we had very few visitors in the first couple of years. We started at that point by saving our information in a data sheet, a plain old Excel spreadsheet, and what we realized is that we were not able to track down about 50% of the patients that were seen in the hospital setting. So once they left the hospital setting, we were unable to find them, and because we were unable to find them, we weren't doing a very good job of encouraging the fracture follow-up, evaluation, and treatment. While we were doing that in tandem, we also were setting up other hospital and community resources. We started a free osteoporosis exercise class that emphasized weight-bearing exercises, strengthening, and proper biomechanics. We developed a personal physical therapy evaluation program that the patients could be enrolled in. We worked with home health nursing on home health visits and fall prevention and DME prescription. We networked with an agency. Here it's called Alliance for Pharmaceutical Access, but you could look it up and find out what resources you have in your area, called the Safety Net Foundation. And that's a way to access medications for patients that lack financial resources to get their medication. We also started an infusion center on campus, and we did this all in parallel. About the same time, we started going to community lectures and nursing homes and offering free heel or wrist ultrasounds as a way of capturing the patients that did not have access to DEXAs. We also co-sponsored any health fair where there was something going on with cholesterol testing, cancer detection, heart disease screenings. We always called and offered to bring our machines to them. And one of our most popular programs is working in conjunction with the senior centers that do senior fitness testing or car safety, and helping them and providing additional testing and ultrasound testing. All right. So then we move forward to 2012, and we decided that with the advent of the electronic medical record and a movement towards Joint Commission evaluating accreditation for osteoporosis programs, we decided that we should work on a more regional level. And I am lucky to be working within the Dignity Health System, which in our small region, this beautiful coast of California here, we have 3 Dignity hospitals in San Luis Obispo, Arroyo Grande, and Santa Maria, California, and we work with the same administrative staff in all of these areas. So what we decided is that we should coordinate our services and work together and try to do a better job of capturing this information and making it scalable. And so for today, we're going to talk about how you can do that in your unique setting, about how you would decide to fund your program, who you need to work with to make this happen, and really, unfortunately, you do need to really have an intimate relationship with the people that will be providing and working with you for your electronic medical records or data capture. And finally, I'll end with a couple anecdotes about what we definitely did wrong and the things that we can do to improve. So when we started off, we had to look globally at the interaction between patients, the hospital, the clinicians, and the insurance companies, because all of these are involved. It doesn't do any good if the hospital tells a patient that they have osteoporosis, if the clinician doesn't reinforce that, or if the insurance or the regulators don't pay for it. So as we're walking through these scenarios today, you have to keep in mind that there are many moving parts and we really have to keep everybody aligned. So the first thing that you have to do is you're going to have to figure out who's going to be your champion. And this really needs to be somebody who's open-minded and has passion and can work through problems and be flexible, because over the years we have had to change our process so many times in order to adapt and to continue moving forward. And so that champion will also need a home. And if you're fortunate enough to be in a system like Kaiser or a national healthcare system like Canada, then your home in fact be a combination of the hospital working with the clinicians or the insurance systems. But where I am at, we are all fee-for-service. The hospitals are separate, the doctors are separate, and so we really have to coordinate all of these organizations in order to function. So, you know, the list is quite big. It's some locations, endocrinologists, rheumatologists, the geriatrics division, orthopedists may be more likely to be heading this up. I'm actually a physical medicine rehab doctor or a physiatrist because I see non-operative back pain and rehabilitation patients after fractures. So, of course, I think we're ideally suited. A lot of the renal doctors have taken on this role. And what we may be seeing in the future, too, is that either a hospitalist or the hospitalist outpatient counterpart may be intricately involved in this, or as the new medical home model becomes more popular, this might be a good place for the champion to be at home. So the reason you have to think about all of this is in context of where the contacts are made with the patient. If we look up here, when the patient first enters the hospital system, maybe through the emergency department, there is some basic information that should be conveyed at that area. And I do believe that this is one of the metrics that the Joint Commission has looked at in 2 versions of their testing, and that is, in the emergency room setting, was the patient advised and given information in their discharge instructions indicating that they may be at risk for osteoporosis, and in fact that this fracture may be due to osteoporosis. But on the other hand, the emergency department probably isn't the place to be doing a secondary workup for osteoporosis, to be getting a DEXA scan, to be getting an endocrinology consult, but it is one way to think about the first point of contact with the patient. The second place to look is in the inpatient. So if a patient is admitted with a hip fracture, again, that's a teachable moment to talk to the patient and talk to the patient's family about possibility of underlying osteoporosis that led to their fractures. And so at stage 2 is where you're going to be thinking about the orthopedist or the hospitalist coming in contact with the patient. Hopefully some patients get to go home. In my practice, it's very elderly, so not that many patients end up going home. But almost all of my patients end up at some point in a skilled nursing facility for some period of time. And at the end of this, I'll tell you that one of the lessons that I've learned is that we probably are not putting our resources and our investigative abilities in to the right location. I think the emergency department and the inpatient processes are too fast and disconnected maybe from the patient's outpatient setting, and really we have a much more captive audience here in the skilled nursing facility or the acute rehab hospital. On the same token, if a patient is then transferred to long-term care, that's a very captive audience. And right now we've been focusing on intercepting the patient back in the primary care office, when a lot of us know that when the patient shows up here in the primary care office, they may never tell their doctor that they were in the hospital or had a fracture because they may have just been seen in the orthopedic office. So the model that we use is our gold standard is the Kaiser Healthy Bones program. And Dr. Dell spoke on the last webinar, and for those of you that missed it, it is archived, and I recommend that you go back and see it and listen to it. And their program, in summary, has basically shown that if we do the right things for the patient, we will realize a cost savings attributable to the reduction of future hip fractures. Okay, so basically the healthcare system is going to save money for doing the right thing and taking care of the patients. So what makes us different from Kaiser? Well, at Kaiser, all of these entities are aligned, and unfortunately in my open system, they aren't aligned. The hospital may want a decreased length of stay. The patient may want to move out of the area to live with their daughter. The clinicians may not even be aware of this hospitalization. And then, of course, we're all faced with the regulators and the insurance companies and the Part D programs that are very involved in our ability to provide care to the patients. So what I suggest is thinking along those lines of where the interested parties in your group, where do they come in contact with the patient? And so our model here has found a home in the hospital. And we started off in the chronic disease department, an outpatient department, because there was a good example with our congestive heart failure program. As we matured, we became very good friends with our counterparts in the quality improvement department because we rely on them for information and data queries. And where we may be moving is working with our Department of Orthopedics, because we have found that the same patients that are having fractures and hip replacements, there's a high overlap with the orthopedic total joint patients, and so it may be that that's the best synergy for us to work with. That doesn't include working with the internal medicine subspecialties, but in our situation, those are the other departments we've worked with. Now, if you're in private practice and you want to provide a service of the fracture liaison service in the community, then it also makes sense to think about doing this privately through your orthopedic practice, through a physical medicine practice. As I said, I see a lot of potential for the patient-centered medical home model, and these would be structured differently because you would be obtaining these patients through your private practice and not directly from the hospital. Now, again, if you're in a managed care system, and when I first wrote this slide, I meant a managed care model, but with 5-star Medicare ratings for Medicare Advantage plans, this could also apply. And if you're working within the managed care environment, then again, that system will help you find a home with a champion, and you would be part of the cost savings or reduced medical losses by providing this care. So how do you find out if you're going to be able to make this work financially? Well, you have to go back to our last slide and decide how you're going to approach this in order to understand how you're going to fund it. So your choices really are a closed model like a Kaiser system. The new accountable care organizations would be similar to a Kaiser. If you had a hospital-sponsored nurse navigator program, you'd be working out of the hospital situation. A patient-centered medical home model would be part of the total care, and the private practice model would be private care. So I'm going to explain how you could possibly fund those situations. So if you're at Kaiser, the doctors, the nurses, your QI and UR teams are all in alignment. They have shared open access, and a lot of these roles may be shared. So the patients can be identified, contacted, and treated jointly by somebody in the entity, and all that information is captured, and they can basically job share. And as I showed in the previous slide, the reimbursement, the payment for this program is actually realized in the decreased fractures, readmission costs, and the improvement in the quality of life. It's the absence of future hospitalization costs for future fractures. So obviously, this program has a tremendous benefit this model has a lot of benefits for everybody involved, okay? Now, if you're going to be involved in a new ACO or you're a private practice and you're partnering with a hospital, if you're in academics and maybe your private practice clinic is actually under the same tax ID number as your hospital, then you will be functioning more like that Kaiser model. Now, the other way to do it is to have this be a hospital department, basically, or part of a hospital department. And what that means is the hospital supports this position, like a chronic disease nurse. And like I said, in our community, we have a a cancer nurse navigator, a diabetic specialist, and we also have a congestive heart failure nurse. And they work with the hospital, all the departments, to identify the fracture patients, and then they nudge the patients to the specialist, and that's what we've been doing. The advantage is I can target all the patients that went through our hospital system, but the disadvantage is that there is not an actual health care provider that writes that prescription for the DEXA or for physical therapy or for the medications. And most of the research points to that this model falls short because you can educate the patient, you can educate the doctors, but there is a big care gap between that education and the actual compliance of having the prescriptions written and the patients following through. And I will tell you that that has been our experience, and we're working on changing that model. So I have been asked questions before about what you do for coding. If the patient is in the hospital under a code, a global code, then if a alternate specialist, an endocrinologist, a rheumatologist, or say a nurse practitioner or physician's assistant from another office comes in to consult and order these items, then they can simply code for the underlying diagnosis of osteoporosis, and they may need a modifier 24 to indicate that the treatment is for osteoporosis and not actually for the fracture care. Now, if the hospital has a medical home clinic or a clinic under the same tax ID as the hospital, and you're giving the patient one of these new transitional care visits a week after they're discharged, then the hospital can also choose to bill for that transitional care visit. Okay. Now, if the hospital itself is not involved in the fracture liaison service, and say there's an orthopedic practice that wants to take on this responsibility, then what they're going to be doing is they're going to be querying their own patients that were in the hospital or their own billing system or their own medical record system, and they're going to actually run that program with the staff out of their private office. Now, this model has benefits because you know who the patients are, but only if they belong to that orthopedic group. If they belong to another orthopedic group, you won't have access to that information. One of the strong benefits of this model is that you already know the patients. They're coming back to your office for suture removal or staple removal, and you can be very clear with them that this fracture may be secondary to osteoporosis, and that it's not a completed scenario until the evaluation is completed and treatment instituted. You have that teachable moment and that authority right now because you were the doctor that did their surgery, you touched their bone, you know that they have soft and fragile bone, and so I think that this is a great opportunity, but it does take extra staffing or extra organization to add this to a list of things to do for the healthcare providers in the orthopedist office. So the question is, can we take good care of our patients, and will that cover the cost of your program? So what we did a couple years ago is we went to a module called Own the Bone, which I will go into more detail in a couple of minutes, and they have a revenue model. And in that, you look at the number of fracture patients that your entity identified as having a fracture, and then you look to see which ancillary services your home or your institution offers. And basically what you're doing is looking for lost revenue opportunities. So, you know, the standard of care is after somebody's had a fracture, they should either have a DEXA scan for evaluation and or treatment, and we're falling short of that. So basically what you're going to do is you're going to say, how many opportunities did we miss to provide the standard of care that also would be revenue centers to, in fact, fund our program. And so what we did is we went through, and we have an unusual situation here. I'm a big proponent, but our current hospital does not even have a DEXA machine. So we have a huge potential for revenue increase from obtaining our own DEXA machine. But what about all the compression fractures and or burst fractures that may need advanced imaging? Our physical and occupational therapy was sorely underutilized, and probably because they were going to outside private facilities after they were discharged. We only had a couple patients that were utilizing our infusion services. They were going to outside facilities. Again, we have so many lab opportunities around here. Most of the patients were not getting their lab service back through our hospital system. They were going to other outside private labs. So these are ways that you can realize potential lost revenue, but there's other ways to fund your programs. By avoiding readmission penalties, which is, a new Medicare issue, you may be avoiding penalties in the future. We're going to talk about earning pay for reporting or pay for performance incentives. And then lastly, there's this nebulous area that I will call clinical documentation improvement, and that is learning to code to the highest specificity so that the hospital is paid more for doing the right program in the hospital and for the hospital patient. So what we did is we queried our fracture list, and then we gave that list to our outpatient billing services and asked them how many of those patients used our outpatient services. And in one of our 3 hospitals, we found we had 0 ancillary service usage, absolutely 0. So obviously there's room for improvement. And at 2 of the hospitals, and at one hospital, we were only utilizing those services 23% of the time. So we have a great mechanism to keep the patients in our system, understand their care, and generate revenue. The other way of not losing revenue is looking at clinical documentation improvement. And this is a hypothetical situation. I don't want anybody to think that these are real numbers. But we have a situation where there are audits for low back pain because it's a red flag. It's a symptom. It's not a diagnosis. And we all know that vertebral fracture patients, osteoporotic vertebral fracture patients are challenging, and that most of the vertebral fractures are under red. And so I went back and I said, well, what's going on? How can we look at this? And it all comes down to a definition. When I was in medical school at Ohio State, we were taught that a pathological fracture reflected on the fact that there was probably a tumor or cancer or a lesion that precipitated that fracture, okay? And the definition that our coding organizations are using is not that. Their definition of a pathological fracture is a low trauma fracture, or what we call a fragility fracture. It means that the mechanism of injury, that slight fall, does not account for the resulting pathology of a fracture. And so when you talk to the patient, even though they say over and over again, well, I fell really, really hard, it doesn't matter. If they fall from a standing height, then that fracture is out of proportion to that minimal trauma. And so the reason that this is important is because if a patient is admitted with low back pain with major comorbidities, an example would be DRG 551, which pays approximately $13,400 for a length of stay of 5.2 days. But if the coding physician recognizes that that low back pain symptom is from a pathological compression fracture, meaning a compression fracture secondary to osteoporosis, and that same patient has those major comorbidities, it changes the DRG, it changes the reimbursement, and it changes the length of stay. So we're all being taught to code to the highest specificity, and in this case, not only is it the right thing to do, but it does pay you for the services that this patient requires. So how do we go about starting something this complicated? Well, again, it's going to take a village to organize this. So what you're going to do is you're going to start off with the query. And this is where you make friends with somebody in your IT department. And one thing I forgot to include a slide in here is I'm talking about querying the hospital diagnosis codes. But we also do this in our office. You can query your DEXA machine. You can query if you have an opportunity to look at medications, if they've been on bisphosphonates. You can also query administrative data for any other reasons that you may have been in contact with the patient. So you're going to, in our situation, we queried the hospital diagnosis codes for fractures over age 50. We then reviewed their medical records to exclude traumatic fractures. So if it was a horrible MVA or something like that, we would exclude that. And then you have to input those patients into a registry. After you develop the registry, you're going to figure out what metrics you want to track. And so, as I said, most of this information will be pulled from medical records, operative reports, discharge summaries, but don't forget about looking at the organizational capabilities on your imaging machines, your DEXA machines, to find some of those patients. So basically, the first step is that you're going to query your information system. So this is going to require legal access to this information. You're going to make sure that you have permission to do that within the system that you're working in it, and you're going to give your IT staff the information obtained in the next couple of slides. So remember, you can query this through the hospital, through your electronic medical records in your offices, through your DEXA systems, and also we've been doing it through our infusion centers and our pharmacy data. So what you're going to do is you're going to look at fracture codes. Now, the code listing that we used is taken from recommendations from the Joint Commission's 2008 osteoporosis monograph, and it's the link is listed here, and you can look for it in the Own the Bone materials and the Fracture Prevention Central materials under the handout section. But for purposes of moving this talk along, you're basically going to be looking at codes for hip fractures, wrist fracture codes, vertebral fractures. Dr. Richard Dell has written a query for the EPIC system, his medical record system that they use at Kaiser, and we have a query written for anybody to share that uses Meditech. That's our current electronic medical record at the hospital. I'm obviously not going to read these, but this is the example of the codes that we query. When we query those codes, we also ask our query output to include name, date of admission, date of discharge, the physicians that cared for the patient. This is very important to consider the discharge location. Phone number, we now have an alternate phone number because if the patient doesn't return to their home, you may need to get in touch with their family members to track them down. We also go by ethnicity, zip code, and insurance so we can identify any discrepancies in demographics. We look at the emergency department, which we hold to one set of metrics, our inpatients, which we hold to another set of metrics, and then you may get overwhelmed depending on whether you look at all of your outpatient procedures such as radiology and lab, and so we actually chose to get rid of looking at lab and radiology. We only ER patients and inpatients. So you take that information and now you have to put it into a registry, and it may be as simple as an Excel spreadsheet. You're going to download the information from that query, and then you're going to add additional columns to look at whether they were prescribed a DEXA, did they receive their DEXA, were they prescribed a treatment, did they receive their treatment, along with lifestyle and calcium and vitamin D recommendations. One really good option available to you is the American Orthopedic Association's Own the Bone, which is a web-based program that will do all of this for you from this point of the talk on. You have to query those patients, but then you will actually enter them into this registry, and then this registry will generate information for the patients, for the referring physician, and more importantly, it will aggregate this data, and it can be submitted to Medicare or other pay-for-reporting groups in the future. Now, that's an option. The other option is to write a custom program that your in a program that your hospital or your system already uses, and that's called a CQM, which is a clinical quality measure product, and that is a product that interacts with your electronic medical record, aggregates the data, and then submits it to CMS for pay for reporting. So we did that. That's been our big project for the last 9 months, and we are working within a product called Midas Plus and developed a focus study that we hope will be rolled out to other Dignity hospitals soon, and eventually the Midas Plus library, which is owned by Xerox, if some of you are wondering whether you have access to that. So why are we doing this? We're doing this because we're moving to pay for performance, and on the way we're stopping at pay for reporting. So right now we can either earn applause by reporting our good deeds and hopefully get incentives for these good report cards, with the understanding that eventually there might be a penalty if we don't meet the thresholds in the future. So we're trying to be proactive. Now, most doctors are overwhelmed by metrics and they resist them, but hospitals now are growing to love report cards. What are we going to be measuring? What are those metrics going to address? These are my suggestions based on our involvement with some studies, and it's going to be whether the patient's being evaluated after the first fragility fracture, whether they're being treated after the first fracture, if they've been given adequate calcium and vitamin D recommendations, lifestyle risk factor modification, advised on weight-bearing exercises, and fall prevention. So this is a busy slide. It's obviously going to be a lot easier for you to see it when you look at this on your own, but this just shows you all the different available metrics. So if you are in private practice, you may be submitting PQRI data, which is in your electronic medical record system. If a patient comes to see you for a fracture and osteoporosis, you can meet a couple of these metrics by saying that you screened them for future fall risks, you communicated with their PCP about treatment, you prescribed treatment, you counseled them on calcium and vitamin D. You check off those boxes, and that's populated and sent to CMS, and you hopefully get an incentive. Now, there's several other metrics which are listed here, the NCQA and the HEDIS. The AMA has some metrics. The Joint Commission will be coming forth with their final pending set in the fall. And what Own the Bone does, which is listed in the middle, is this is a web-based program that looks at all of these, some of them are overlapping, but then it will sort them out at the end and allow you to submit them to the right agencies. So these slides were given to me by the AOA's Own the Bone program, and it basically goes through what I just said, is that these recommendations cover many different of the agency's metrics, and they will help you organize and register these patients they will help you organize your own registry so that your data can be submitted for pay for reporting. And again, it covers the basics standard of care, which is calcium supplementation, physical activity counseling, lifestyle counseling. It also, you input whether they got their DEXA, whether they received their treatment for osteoporosis, and it also documents that you educated the patient and the primary care doctor. And this is just a screenshot from how you work within the bone registry. Now, what we did is we organized our data query through our electronic medical record, which is Meditech. We already have an existing contract with Midas Plus, which already does focus studies, utilization studies, quality improvement studies for all of our hospitals and on a network basis, and then those are submitted. So we said, okay, let's make a specific one for osteoporosis. So this won't mean much to you, except that in the utilization review now, we can, on a daily basis, with a click of a button, we can look at we can look at utilization indicators in this case. And then this is a screenshot of what our focus study for our clinical outcomes looks like. And so these are questions that I wrote that we're answering, and it says for patients that were admitted, were we able to document that they were given their discharge instructions? Was there documentation that we knew about their prior diagnosis of osteoporosis? What is their discharge disposition? And were basic tests done for evaluation of underlying osteoporosis for secondary causes? So this is just a screenshot, and I'm happy to share our other questions with people. And I'm sure that'll be one of the most important questions. So one thing I want to bring up is that all of the indices reference DEXA. And when you go back and actually look at the Joint Commission's recommendations from 2008, what it said was patients age 50 or over who fracture, who either have a DEXA ordered or performed or a prescription for FDA-approved pharmacotherapy for osteoporosis prior to discharge. And for the HEDIS measures, this is over age 67. But if you go back in the original manuscripts, what it actually says is underneath it is if DEXA is not available and documented as such, then are there any other FDA-approved testing method may be used, such as QCT, this stands for ultrasound, PDEXA, et cetera. So one thing that I think that we realized is that maybe we're being too strict with the DEXA usage, and there may be some other methods, such as FRAX, BMI, and specific ultrasound for us to make sure that we're meeting these metrics. So what have we learned? In our situation, we have done a really good job of establishing a process and pathways to identify our care gap. But you know what? We are not doing a very good job at all in closing the care gap because we don't have healthcare professionals that are able to order the DEXA, the labs, the therapy, and the medications. And I will tell you that in the next 2 months, we will hopefully remedy this by having a specialist involved through the hospital with prescribing and follow-up privileges in our clinic. We also identified that we need a DEXA machine within the hospital setting, and we will need to continue to expand our use of a portable ultrasound machine if we want to capture the patients that we lost to the skilled nursing facilities, to the acute rehab facilities, and we maybe even back up and do those on the orthopedic floor or have an ultrasound available in the emergency department. Because when the patients are discharged later and they go back or don't go back to their community and not have a DEXA, we really lose them. I also think that since our population is so elderly, we need to put more resources into identifying and treating the patients in the skilled nursing facility. In our population, 61% of our patients are going to that skilled nursing facility, and I think that the treatment is prohibited by the 90-day rule where the skilled nursing facility is responsible for the medication costs And I think we really collectively need to lobby for a carve-out for osteoporosis evaluation and medications so that we don't miss treatment. So just to finish up here, I want to show you how easy it is to perform the HEAL ultrasounds on your patients. If you have to take the ultrasound machines to the skilled nursing facility or to the health fairs or even to the hospital ward, this other machine is a wrist ultrasound machine that we're piloting because a lot of our hip patients obviously can't have their heels tested. And I know this was a lot of information. I anticipate there's going to be lots and lots of questions. We're going to try to answer those online, and this webinar is going to be archived for people to listen to it. You're going to log back in, and I also want you to take advantage of the evaluation that we have at the end of this, not only for feedback for me, but we want to capture some information of who you're calling from, where you're calling from, because we want to make sure that we tailor our new programs to meet your needs. Okay? So, David?
Yes, great. Thank you. And just wanted to address the first couple of questions that have come in, which related to whether there was going to be an archive of this, which Mary just answered. I also wanted to give folks the link to the first webinar, which, as Mary said, is now archived. So I just sent that to everyone. Hopefully that actually is coming through now. That gives you the direct link in which you can access that first webinar. And we will be having 4 additional webinars throughout the end of the year. I guess we'll have one in August, and then we'll have one in July. We'll skip August, and then we'll do September, October, November. So thanks so much. Maybe I'll bring it back over to Mary to start answering some of these questions.
Okay, so first of all, I have to say that technology is really amazing because I see a friend of mine sending her question in from Romania, and Carmen is asking us she's saying that her hospitalization and additional care funding is different, and her question is related to the involvement of the managing doctor. She feels that the program won't be successful unless the doctors are involved, and do I think it's possible to work with so many doctors? I think that, Carmen, the answer to this is that they need to be involved, but that you don't want to have too many cooks in the kitchen. You do need one person to be the managing organizer, without a doubt. You need them all to be helpful and referring and be supportive, but you do need somebody to be actually in charge. Okay, we have another question. Will the PowerPoint be available for us to print? David, I'm going to let you answer that.
Sorry. Yes, definitely. And actually, if you go to, there's a handouts tab, and among the materials there is the. Actually, it's not. I'm sorry. Sorry, I was thinking that we had uploaded the PowerPoint, but when this goes to archive status, we will be able to have access to that. And I know that folks also on the last call had requested getting the actual PowerPoints as opposed to a PDF, and we'll make sure that we upload both of those versions so that folks, if they want to use the slide or so, of course, with attribution to Dr. Oates, that people can do that.
Okay, and I have a question from Donna, Midwest Primary Care. She says she's a nurse practitioner, FLS coordinator. Yay! And she's encountering issues with insurance covering meds. I agree this is one of the most challenging parts of our job. That's where you have to be very resourceful in gathering either operative reports or just coming outright and telling the insurances that, listen, they broke their hip, they definitely have osteoporosis, this medication needs to be covered. We discuss with them how if they're in the skilled nursing facility, that, they may not be amenable to oral bisphosphonates or some of the generics because they can't be in compliance with the instructions. But we are relying heavily now on the pharmaceutical companies' programs that help us with prior authorization. But for sure, it has definitely been a barrier in the skilled nursing facilities because those meds come out of the per diem for the skilled nursing facility, and I think it should be more similar to either the dialysis or the oncology programs where those are carve-outs. But, yes, it is a challenge, and we need to all be working together on that. Okay, Catherine from Novant Health Endocrine Consultants. Have I had any experience using virtual visits for SNF or other post-fracture patients? I have not, but our congestive heart failure nurses do use telemonitoring. And so I know that that is available. I don't know how applicable that is, but we will we'll be looking more at that in the future. Okay, Donna from Midwest Primary Care, any advice on prior authorizations? Oh, I think we talked a little bit about this. I'm relying heavily on specialty care pharmacies to help us with the prior authorization, and or I'm using a protocol that we developed for our infusion center that asks all the questions up front so that that information is available to anyone that's helping me process that prior authorization. Okay, Deborah from Orthopedic Associates of Michigan. What is the comparative reliability of the heel and wrist ultrasound of the DEXA? This is a great question. The DEXA is the gold standard. The problem is it's not portable and it may not be available, or the patient may not be able to participate in that exam. So we are using the heel or wrist ultrasound in alternate settings in our situation to encourage patients. We say, listen, you broke your hip, and they say, well, my doctor said it was healing well. And then I have to say, well, it's healing well, but the underlying bone is osteoporotic. And they say, well, how do you know? And so I at least have a number that I can talk to them about. I can say, this ultrasound shows that you're at high risk of osteoporosis. You need to take this back to your doctor. We send it to the doctor. Right now, neither the heel or the wrist ultrasound are approved for, they're approved for diagnosis of fracture risk, but they're not approved for monitoring. So you won't have the benefit of, after they're started on treatment, to go back and compare, but we use this as a point of education for the patients and a point of education for the doctors, because some of the doctors we taught too well to rely on T-scores, and despite the fact that the patient had a fracture, they still want some type of a score to help them feel good about initiating therapy. Okay. Laura from Greenville Health Systems. I have been doing Own the Bone for 3 years, and her problem is in the post-fracture treatment. Even with educating a patient, sending letters to PCPs, the patients are not getting treatment or DEXAs. Is anyone having success with this part? Well, I have to tell you, this is exactly what we have experienced, Laura, and so we are moving to the next step, which is basically the Kaiser model of giving someone the privileges to be able to do that. So other literature bears out your experience and my experience, and so I think we'll be looking at this together. Okay. Catherine from Novant again. I understand that CMS does not cover DEXA in the acute care setting. Is that correct? So the DEXA is not covered separately in an acute visit. It's part of their DRG, so you don't get extra payment for that. So her question is, in that case, a portable ultrasound would be useful in the hospital. So that's what we're finding, is that if the DEXA is not available or the patient can't lie on the table, the ultrasound is quick, it's easy, it's portable, and it's not as expensive. So we're looking at that as a viable option for meeting our metrics and educating the patients, yes. Now, I think we've run out of time, but I will be available a couple more minutes to take some more questions from the webinar. And David, do you have any final words?
Sorry, I was muted. Just wanted to thank everyone for being on the line today. I also wanted just to mention that if you go to the Handouts tab, there's some additional information about MBHA, Fracture Prevention Central, as well as Own the Bone, which Dr. Oates mentioned a number of times. And, we work very closely with the AOA, one of our partners here in the MBHA, and certainly a route to get that patient registry, the tools, to get your FLS set up and running. So really pleased to have so many folks on the line today. Also wanted to thank Amgen and Eli Lilly for the funding support around the creation of Fracture Prevention Central and this webinar series, and hope everyone has a great day.
Thank you very much.
And thank you, both of you. On behalf of the National Bone Health Alliance, we thank each of you for participating in today's program. This concludes Fracture Prevention Central, implementation of a secondary fracture prevention program. Where to start depends on where you sit. Please be sure to complete the evaluation by following the link that will display on your screen momentarily. This concludes our program. Have a great day.